Wow. Thank you for all coming to our third annual meeting. It's always most difficult to speak after lunch because of after lunch syndrome, but I will try to entertain you as much as we can. I'm very blessed because I have 3 beautiful children and a beautiful wife back there. I asked them, do you know what this is? And they had no idea because nobody uses this type of phone today. Now, for dentists, it's the same thing. We may feel very comfortable with our conventional procedure, and we may be very used to our conventional procedure, but sometimes we have to step back and think, are we using outdated technique or outdated tools compared to what we have available today? So today I'd like to talk about new concepts, new techniques in dentistry, and how we have evolved from using rotary phone all the way to digital smartphone. So as you can see, many patients will come to your office without any bone. Usually, they have money, but they have no bone. Or they have bone or no money, correct? So this patient presented with money, but no bone. Now we have to do some surgical procedure in order to add bone to our patient. So typically, because we have so many lawyers in the United States, we have to be very careful not to touch the nerve. And I heard in UK, the situation is even worse compared to the United States. So I'm being very careful not to touch the mental nerve so that the patient doesn't get paresthesia on her lip. And because mandibular bone is so dense, we will need to do decodification to increase the blood flow and also to give mechanical and biological retention for your new graft material. So handling soft tissue is very, very important. Here I'm releasing buccal and lingual tissue so that we can get nice tension-free primary closure. And we will use graft material, and we will need to use stiff membrane, a membrane that can withhold external force so that it doesn't collapse during the healing period. It's very critical knowledge. And internal matrix suture, double layer suturing technique is required so that it prevents pulling of the lip during the healing period. So we used to teach all these techniques to our attendees 10 years ago, and it was an exciting field of implant dentistry because 10 years ago, we used to place implants where the bone was. Then we had this great technique called bone grafting, where now we can build bone in any dimension we want with this simple procedure called guided bone regeneration. We let it heal approximately about 6 to 9 months. And when we open the flap, you can see tons of bone formation with this simple technique called guided bone regeneration. No longer now we have to worry about not having bone for our patients, and we can build bone in any shape and any amount we want for our patients. However, this requires good surgical skills and a lot of pain, swelling, morbidity, and the cost is very high for our patients. So it is my belief that this is comparable to old cell phone, old flip phone. Does anybody use this phone today? We don't. So today, when I have very thin ridge like this, where implant is not possible, I will still place implant, making the buccal and the lingual threads completely exposed. Because we have a better material, better graft material, now we are able to go to the next level And anybody is able to do very easy bone grafting by utilizing specialized bone block called spongy bone. Spongy bone allows us to make a minimal flap instead of making huge vertical incision in order to open the flap. Because spongy bone is held by envelope flap, where we don't have to make vertical incision. In fact, if you make vertical incision, it will be more difficult to get good outcome. So by utilizing spongy bone, now anybody is able to build bone with just the envelope flap. And because we're not making any vertical incision, there's less bleeding, and primary closure is much, much easier. So here I'm placing 2 membranes, pericardial membranes, and we hydrate the bone in clindamycin for 10 minutes. As you can see, because it has memory, because it is like sponge, foam, we are able to insert this bone inside the flap. And later on, it will have a memory and it will make its own shape. And because the handling, this bone graft material completely changed the way we practice dentistry. So as you can see, all you have to do is really eliminate the wrinkles in the bone block. And because it's malleable, as you can see, I'm able to put it in very, very easily. And because the palatal flap is very thick and rigid, there is no reason to use titanium reinforced membrane, and there is no reason to use non-resorbable membrane. Therefore, implant surgery and bone graft can be done at the same time. All you have to do is really take care not to have any dead space, and I try to remove any wrinkles in the bone block, and I try to position my spongy bone in the correct location. So especially for palatal defect, this spongy bone is very beneficial. On the facial, it's held by the sutures. As you can see, we have more than 90% of our dental fixtures naked in the bone, and by utilizing spongy bone, we are building bone at the same time as implant placement. So spongy bone, very easy to use, and you don't need to have any screws. So no second surgery is necessary to remove the screw 6 months later. But you do need to learn how to get primary closure, and you need to understand how to utilize multiple layer suturing technique. So here I'm using more FTBA to fill in the gaps, and I like to mix my graft material with either clindamycin or metronidazole. So after packing the bone, we will do internal matrix suture, and primary closure has been achieved. With this bone, you have to wait long enough. Because it's demineralized bone, we have to wait more than 12 months for the minerals to form around dental implants. So as you can see, 6 months is very disappointing because you will not see a lot of bone around dental fixture. But when you wait about 12 months, you will find a lot of bone around these fixtures. As you can see on your left, before we have 1 to 2 millimeter thickness of the bone. On your right, I have more than enough bone for the fixture. Only downside is because it looks like a sponge bone, I had to go back and trim the excess bone. But it's a good problem to have, as you can see, when patients have deficient bone for our implant procedure. So sponge bone has really changed the way I tackle the cases where we don't have any buccal plate, or we need to do horizontal or vertical ridge augmentation. And I'm very happy and lucky to work with many good restorative dentists in San Diego and Boston and in New York. But I believe this technique is still outdated. And my residents know that I don't use this procedure unless I have a very difficult case, because when we open big flap, there's more morbidity to our patient. So I think of this case as an iPhone 2. So what is iPhone 7 for our implant procedure? There's a technique called MIT technique. It's not the Massachusetts Institute of Technology. It's MIT, which stands for Minimally Invasive Tunneling Technique. It is co-invented with my colleague, Dr. Simon Jung. And by utilizing MIT technique, we no longer have to open flap to do ridge augmentation. We can make only one vertical incision. Therefore, there's no need to do extensive suturing. In fact, when I teach my students, it takes longer to suture than actually do the bone graft and place implant. So if we can eliminate suturing process, I think we can shorten our surgical time. So how do you do MIT technique? With MIT technique, we make a very small incision. We try to avoid cresto incision, and we just make one long vertical incision beyond mucogingival junction, because mucosa will expand. And believe it or not, even though we're working through a small tunnel, we're able to see everything. And we will use the back action chisel to remove any residual periosteum. And we will introduce collagen membrane, which will act as a tunnel for us to introduce bone graft material. So here, we are just decorticating and relaxing the flap internally. And we will introduce collagen membrane. We like to use pericardium. And the secret here is you must use this pericardium when it's dry. Once it's wet and it loses its rigidity, then it will be very difficult to do this technique. So we will open the collagen membrane inside the tunnel, and we will inject freeze-dry bone into this tunnel. And then we will massage the patient to eliminate the dead space, to prevent any infection, and just simple suturing technique is done. So very simple procedure, and the bone grafting surgery has reduced from 2 to 3 hours to just 15-minute procedure. So I truly believe that this is the best technique out there. It works really well for the mandibular as well. Same procedure, you just have to respect the mental foramen, and we make a very long tunnel, and we will use collagen membrane. Let's look at the video. So before the surgery, you look at the panoramic X-ray and you measure where the mental foramen is. And you want to stay at least 5 millimeters from the mental foramen and make incision touching all the way to the bone, cutting into periosteum, because your tunnel has to be below the periosteum. If you leave any soft tissue below the periosteum or on top of the bone, this procedure will not work. So it's very important to go below the periosteum and scrape all the soft tissue that you see and use the dry membrane to open the tunnel and then inject. I highly recommend to use syringe. We use diabetic syringe to insert the bone, because when you use the spoon, there's higher chance to get infection from the saliva. So it's very important to use diabetic syringe and inject the bone with just one shot. And we will pack it around, make sure there's no dead space, and we will suture, and patient is done after 15 minutes of short procedure. The beauty of this technique is that patients do not have a lot of pain. As you can see, 1 week later, patients use very, very well. And when you see the patient 6 months later, even 3 months later, you can see that the volume has completely increased. And when we lay a flap to place an implant, it almost looks like a tumor. So this is truly the iPhone 7 of implant dentistry. Right now, horizontal growth only. If you want to do vertical growth, you would have to use sponge bone using tunneling technique. So this is truly the iPhone 7 of implant dentistry. I feel like I'm Steve Jobs. And in our clinic, when we run courses, we like to do split mouth study. So as we know that we can grow bone utilizing this tunneling technique, we can also grow gingiva coronally to reduce.
So these are the latest instruments I developed.
Sensitivity to our
I named
patient.
this technique MIT technique. It's not Massachusetts Institute of Technology. It stands for minimally invasive tunneling technique. So this instrument right here is the key instrument to be able to make a small tunnel and lift the whole gum. It's like doing a facelift. Will bring all the gum tissue down. So this instrument is the key. If you have a bigger space, then you will use this one. Obviously, wider it is, it's more predictable for your technique. And sometimes we do MIT technique to do bone graft. When you are going over the occlusal surface in the ridge, then you want to use this instrument.
What do you mean over
So if this is buccal and lingual, this other instrument,
in the most cervical area?
yes, can go buccal, but going over the ridge is very difficult. So I made this instrument so that you can glide over the occlusal.
Okay, got it.
That way you can lift the gum vertically as well. And afterwards, it's impossible to do decortication to accept bone. So we made this special curette where you can go inside the tunnel to curette all the periosteum. And by doing this, you prepare your site so that it can accept the recipient bone. And then we have this blade where you can change the angulation of the blade. Give me the 15 blade. So, give me another one too, so that I can show them the double blade. So, this is where you can change the angulation. Okay. It's very nice.
This makes a big difference when you're
wanna use
harvesting
this straight,
free gingival
you
graft
have the
or
other
connected
end.
tissue inside
As
a
well.
very small mouth.
Okay.
So changing the angulation, changing the direction of the blade is very critical to be a good
So
implantologist.
sometimes you want to harvest connective tissue when patient has a very thin gingiva, then you want to utilize double blade in order to
So these instruments have a various
Harvest.
angulation and the
connective
length
tissue.
that are necessary
And
to
what
do
you
tunneling
do
grafting technique
After you put your
with
single blade,
predictability.
as you can see here, we attach additional blade, and then this makes a nice double blade for you. And the key about the double blade is that one height should be lower than the other because the height of the palate is not parallel. Okay, so this is a double blade, and inside the mouth is very important to be able to change the angulation as well, so that you can adapt your angulation. It becomes very unique.
So tomorrow and on Monday, we will have a periodontal seminar with Dr. Tom Neighbors, Dr. Mac Ray, and Dr. Drew and I. We will show you this technique, how to do a predictable MIT technique so that you can help your patients in a minimally invasive approach. So as you can see, nowadays, when we do gum graft or bone graft, I don't open flap. We just make a very small incision, and we will utilize our Cobra instrument to be able to move the gum down coronally. And best of all, we do not suture the patient because we found out that suturing causes a lot of micro trauma. So no suturing is necessary. We just position the gum down, If you want to build bone, you can add bone by utilizing decodification with back action chisel, and then you put membrane and so on. But for recession, it is not necessary. So we've done many split mouth study, and it shows that when we use MIT technique without any suture, the results are fantastic. But when we use the conventional technique with lots of sutures and flap, the body doesn't heal the same because we have done more damage to our patient. So it is very important to update our techniques and our instrument so that we don't practice with rotary phone to our patients. So this set of instruments that we created has completely changed the way we approach our patients, and our patients are able to go back to their work and their regular lives immediately after our surgical techniques. But please keep in mind that when we have narrow ridge, the best way to build bone is actually through orthodontic technique, and still, as a periodontist, orthodontic techniques are important part of our practice so that we can give comprehensive treatment to our patient. So for sure, this is the iPhone 7 of implant dentistry. Now, when it comes to dental implants, Brennemark taught us that we have to use multiple implants in order to reduce heating of the bone, to reduce the temperature of the bone. But when we use multiple drilling sequence, there are more chance for us to make mistake. Also, Brennemark taught us to use a lot of irrigation, and Erickson and Arberson also published that greater than 47 degrees Celsius, the bone becomes burned. So instead of taking the old approach, isn't there a better way? Isn't there an easier way where we can help our patients? So please stop using the old technology. Here at IADI, after 1 year of research, we came out with single-step osteotomy. That is correct. Single one-step osteotomy. Any implant size, we're able to use only one burr and finish the osteotomy. With innovative company like Dio Implant from Korea, we're able to finish this technology. And now we're able to finish any implant surgery less than 10 seconds. You will see during my live surgical stream, implant surgery is no longer a 30-minute procedure. Why? Because we don't have to use water. We don't have to use multiple drill. We just use one burr and we finish our osteotomy. Isn't that fantastic? What is the secret? The secret is in the hollowness of the burr. When the burr is hollow, it creates less heat. And the cutting edge does not contact the bone as much. Therefore, we are able to collect the bone inside this hollow space, and also we reduce the temperature during the osteotomy. Instead of using irrigation, we put these burrs in the refrigerator. And then we use one shot, and we can collect lots of bone for our procedure. If you are using 4.0 implant, I recommend 3.3 for the mandibular. If you are using 4.5, then I recommend 3.8 millimeter burr. Now, those of you who use different implant system, you can use this burr and then use two-step osteotomy technique. So you can finish your final osteotomy with your implant kit that you are using. But still, it will save a lot of time. And the apex of this burr is so sharp that even in immediate implant cases, we're able to do osteotomy in predictable manner. So please utilize the iPhone 7 of implant dentistry, which is 3-in-1 kit. Now, then what are these extra things that I included in this awesome technology? Sometimes we don't have time to make surgical guide because patient had trauma and had a fracture, or patient came unprepared and you need to do implant surgery on that day. Then I give you special surgical guide where these stoppers will act as a surgical guide so that you can position your implants accurately with these burrs. As you can see, because the burrs are hollow, we're able to collect lots of bone with this technique. Why throw away the precious autogenous bone that patient is giving to you? This is the best bone graft in the world. Why? Because it has osteogenic, osteoinductive, and osteoconductive properties. So we can collect lots of bone. And with this one-step drilling sequence, it also comes with premolar locator and also molar locator. So if you want to do premolar surgery with this burr, you just select the length. This is 7 millimeter length, this is 8.5 millimeter length, and this is 10 millimeter length. So here, this is 7.5 millimeter diameter, 10 millimeter length burr. As a right-handed surgeon, I always have difficulty when I treat my patients on the left side because we have this blind spot. I cannot see the left side. So how can I overcome this blind spot issue? Well, if I had a stopper with the diameter of a molar, then even though I cannot see, I am able to position myself in the middle of our final restoration, because our final restoration will be 10 millimeter in diameter for molar. So I utilize this concept so that I can always position myself in the middle of our restoration. So with this kit, we are able to position ourselves in the middle of the restoration so that I don't have to make excuses to my referring dentist that I had a bad day doing the surgery. So even a blind spot is not a problem, and we can always put our restoration in the middle of our future crown by utilizing this 3-in-1 kit.
Job.
So as you can see, even in slanted bone,
100 RPM?
with the deficient bone, we will use this 3-in-1 single-step osteotomy. Even if we have complete fenestration of the bone, we will graft them because we have the autogenous bone from our burr, and because we have the best available bone in implant dentistry, we will have predictable outcome. So this is truly the iPhone 7 of implant dentistry. Yes?
What is the speed of your
100 RPM. Now, when it comes to sinus lift, I used to open lateral window with my famous bottle opener technique. So instead of using piezo or instead of using burrs to outline, I took a concept of Coca-Cola can, and just by making a pre-cut groove, you can open the Coca-Cola can in predictable manner. So I took that concept and translated into lateral window technique. So here we are using cookie cutter, which is a trephine, which weakens the bone. After the bone is weakened, we can use the bottle opener to pop open the sinus. And I've been giving this lecture since 2008, for almost 9 years now, on this specific technique. But there are limitations to this technique. Sinus is never flat. And in order to put this cookie cutter and bottle opener, we had to open flap way higher, almost below the zygoma. Then patients have more swelling, and patients had more trauma. But compared to conventional technique, it was much quicker, much faster, and it was a really good technique. So I think this technique is comparable to iPhone 2. And today, I want to show you a better technique where anybody is able to open sinus in less than 3 seconds with predictable outcome. So how can we deliver easier technique to our patients other than my famous bottle opening technique? What other technique do we have where we can improve from iPhone 2 all the way to iPhone 7? Now, those of you who know my Cresto window technique, we're able to lift the sinus in a flapless manner, but still this has limitation. It's very technique sensitive, and it was very difficult to teach many doctors around the world how to use this technique. So isn't there a better and easier technique than my conventional iPhone 2 level technique? I'm very happy to introduce our new technique where it combines the lateral approach and Cresto approach together. Now, no longer you have to buy 2 separate kits for lateral window or Cresto approach. I have combined the lateral approach and Cresto approach together, and I named this Ultimate Cresto and Lateral Sinus Kit. This is truly the iPhone 7 of sinus lift. So once again, you just need these 2 burrs for lateral window. For Cresto window technique, you need more burrs because it depends on your diameter of your fixture. So you will select 1 millimeter shorter, smaller than your planned diameter fixture. So as you can see, this patient came in with severe periodontal and decay. We extracted and we elected to do lateral window technique. And I just want to show you quickly how to do lateral window technique. We have a special burr where the water shoots out as we are drilling. So when we penetrate the sinus floor, as soon as we are penetrating, the water are scoring and protecting the Schneiderian membrane. This is the safest and the fastest way to open sinus without rupturing the membrane. Afterwards, we will use side cutting burr. Again, the water is protecting the membrane, and you are extending the window into any shape you want. Before, I was limited by making perfectly round shape, but now I can make any shape of window I want. So truly, this is iPhone 7 of sinus lift technique. So as you can see, we try to perforate, but it's almost impossible to perforate because the water will protect the membrane as we are drilling. And we will verify the membrane is intact, and we will inject bone, and we can have a very predictable sinus lift outcome. How about Cresto approach? With the Cresto approach, once again, it depends on your final diameter, and it comes with a stopper, so anybody can do. This patient walked into my Boston office with a fractured root, and she said, you know, I've been waiting to get more implants, but I've been always scared of doing sinus lift. And I told her, don't worry, because we have the iPhone 7 of sinus lift. So with this technique, I extracted this tooth, and afterwards, because the water will protect as we are drilling, it will prevent any unwanted rupture. And I recommend high pressure water. And you can see the water is not coming from the middle, but from 4 holes on the side. Why? Because sinus is never flat. Sometimes it's at an irregular angulation and location, and it is very critical that the water are scoring from multiple directions so that you are protecting the membrane 100% as you are making your osteotomy. So we placed DO implants, and I love using DO implants because the coronal parts are slightly wider than the body, and especially for maxillary implants, I get excellent initial stability even with just 1 or 2 millimeter of initial bone height. So implant shape is very critical in achieving good initial stability, and DO implant has been fantastic in my practice. So after we packed the bone, we have placed DO fixture, and then I took an X-ray, and as you can see, we have elevated the membrane very, very nicely with this technique. Now, packing the bone inside the very small hole is very difficult. It's very time-consuming. So isn't there a better way to do? So we invented something similar to Lancelot spiral, where you can introduce the bone graft material through this osteotomy very, very quickly. All you have to do is just go very close to this Lancelot spiral, and it will kick in the bone graft into our sinus cavity. So 2 more implant has been placed, and I will just skip the implant insertion, and primary closure has been done. And as you can see at the final X-ray, patient has received very, very predictable sinus lift procedure. So this is truly the iPhone 7 of sinus lift. Lastly, this patient flew all the way from Africa to get treated in San Diego because nobody dared to touch this patient. As you can see, the mandibular nerve are so low that putting an implant is too risky. And nobody wanted to touch this patient. When he came to my practice, he told me he's a very busy person. He cannot afford to come back to San Diego, and he was seeking a very predictable technique where he doesn't need to come back all the way from Africa. But the problem is the nerve is so close, placing these implants are very, very difficult. And I recommended to use short implant, but he said he wants to have very, very long implants in order to have longer lifetime of the dental fixtures. So I placed this dental implant for him. Very, as you can see, it's beyond the inferior alveolar nerve. When you look at the X-ray, we have just missed the nerve. On this cross-section, we also have just missed the nerve. And also, as you can see in this slide, I also was very lucky not to touch this nerve. And on the final implant, we were also very lucky not touching the nerve. But can Dr. Lee be lucky 4 times? It's very difficult to be lucky 4 times. So what is the secret?
Okay, so we did bilateral nerve repositioning. We did this yesterday, we did this just today. Mm-hmm. You feel this completely, right? Mm-hmm. Completely normal. Mm-hmm. And you feel this completely normal. Mm-hmm. Same as this one. Mm-hmm. Yeah, so it's amazing how...
As you can see, patient has no paresthesia on the next day. So we had a nice drink in our house. And the secret is that 70% of the time, the nerve runs lingual to our implant site. So even though you see the inferior alveolar nerve on the X-ray, don't fear. And because I utilize guided surgery, this was piece of cake. I cannot be lucky 4 times. It was all planned from the beginning. So please utilize the iPhone 7 of implant, which is digital planning and guided surgery. Don't use the old technique. As Dr. Brower mentioned, this doesn't give us the angulation, it only merely gives us location. And it's not as accurate as guided surgery. So with proper planning, we can avoid blaming each other for poor outcome. With proper planning, we're able to deliver the best dentistry to our patient. So I want to compare what is the iPhone 7 in your practice and what is the older technology in your practice. If you are still taking impression for your patients, please think again. We have a better technology called 3D scanner. My patients, a lot of patients gag, and it's difficult to take impression. Rather, take a digital process where we can scan the patient in a comfortable way and in a more accurate way. I've been using 3Shape in my practice for the last 1 year. Even the full mouth cases that we deliver are very, very precise in terms of fitting. And I was very impressed with the technology. Don't be fearful of wrong angulations, being too close to the root, or being too close to the nerve. With digital planning, we can avoid accidents to our patients. And I believe today, standard of care is to use computer-guided surgery. So rather than opening flap, causing a lot of bleeding and pain, why don't you use digital surgery so that you don't open any flap to your patient? Why are we opening the flap and doing bone reduction where we can do digitalized process where patient is not bleeding, is more accurate than freehand, and patient will love you because we can even deliver prosthesis on the same day. Compared to open flap surgery, after we suture, it's difficult to take impression and it is difficult to make final prosthesis within a short time frame. So I recommend to use digital process. As you can see, on the day of surgery, there's no bleeding, there's no pain after the surgery, and patient is able to chew and function just as if patient had natural teeth. So in 2007, please use smartphone and please use digitalized dentistry. Even my son, who is 5-year-old at that time, is able to place implants very, very nicely because all you have to do is follow the osteotomy set by the guide. If you were to freehand, it's very difficult to draw nice straight line. But if you have a ruler, anybody can draw 2 perfect parallel lines. Thank you very much.